Hi, everyone. I'm Bob Levine. Welcome to our ninth AO Hotseat Podcast, where we explore science, mentorship, and the future of implant dentistry. Tonight, Joe Kan and I are honored to be joined by Dr. Lyndon Cooper, prosthodontist and dean of the Virginia Commonwealth University School of Dentistry, one of the nation's leading dental education and research centers. He formerly served as dean for research and head of the Department of Oral Biology at the University of Chicago College of Dentistry, and has also held leadership faculty and research roles at the University of North Carolina in Chapel Hill. Dr. Cooper is a past president of the American College of Prosthodontics, recipient of multiple national and international research achievement awards, reflecting his deep commitment to advancing dental science, education, and patient-centered care. He is particularly well known in osseointegration and translational research, emphasizing long-term outcomes, biologic principles, and risk assessment, rather than purely technique-driven implant placement, authoring over 200 peer-reviewed publications. His passion for helping others grow, qualities that make this conversation tonight especially meaningful when it comes to his clinical wisdom, which he will be sharing on several topics. So tonight we'll focus on three themes: leadership and mentoring, the evolution of digital dentistry from single-tooth implants to full-arch restorations, and how clinical wisdom helps close the gap between marketplace promises and real-world outcomes, particularly when considering the longevity of full-arch restoration designs. We'll conclude again tonight with a few books that we'll be sharing, as well as audiobook recommendations that support not only curiosity, but lifelong learning. Dr. Cooper, it's a pleasure to have you with us. To begin, please tell us about your journey, where it started, the mentors that shaped you, and how those experiences led you to your present leadership role at VCU.
Bob, Joe, and the entire AO community, thank you for letting me join your home this evening. The AO has been my multidisciplinary home since 1994. And I think that is a very important inflection point. But to answer your question, Bob, I was a young kid who grew up in a small community where most people didn't go on to college. I found myself not paying any attention to anything but cars and girls in high school. Found myself to be a good enough student to go to college. And in a summer job, I remember driving down the road in Buffalo, New York, down Main Street, not far from the UB campus, and there was a sign that said Dental Aptitude Testing, Kaplan Center. I'd never once thought about being a dentist, and I pulled over and I walked in and I asked all about it, went home and asked my parents if they would loan me the money to write the check to go get the books. I had a job as a bartender that summer, and I took the books, and behind the bar at 4 PM we opened, there were never any customers. So I would study every day religiously until the first customers showed up. And it was always good fodder. They'd ask me what I'm studying. I said, oh, I'm thinking of being a dentist. Well, I took the test, did very well. And as a remarkably aggressive young kid, I walked into the dean of the students at college and said, I'm not coming back my senior year. I'm going to go to dental school. He said, you can't do that. I said, no, I've looked. There are 5 schools that accept my application. So I applied to them, found myself at New York University for this with no other reason other than you grow up in a small town, you got to live in New York. There I met wonderful mentors, really remarkable people, prosthodontists like Jerry Barrick, Jonathan Ferens, Frank Panow, people that really cared about my education. I also met oral pathologists like Barry Rifkin and Joan Phelan, who really drove the notion of science being important for me. They suggested that I needed to go do a general practice residency. I ended up at Long Island Jewish Hillside Medical Center, where I had another great mentor in Jim Shuba and also Leon Eisenbud, who was retiring. Jim kept telling me that I was going to be bored in practice and I needed to do something, and my mind was set on research. Interestingly, I didn't pay attention to his advice. I went back to Rochester, New York, where I found a wonderful job as a dentist. And during that period of time, I also met John Featherstone. John eventually became the dean at the University of San Francisco School of Dentistry. But at that time, John was running a research laboratory, and I got my first taste of the arduous pathway to research, but really enjoyed it. After 2 years of practice as a young person, very young for practice, I became bored with those 4 walls and had the opportunity to become part of the dentist scientist program where I went back to school for my prosthodontic training and my PhD in biochemistry and molecular biology. There I had two great mentors. One was the most remarkable prosthodontist, Eric, who really cared about my scientific progress. The other was Larry Tabak, who eventually became the director of the NIH. And there I received the highest level in prosthodontic training, but also I would consider a great education in basic science. At that time, in 1985, I was introduced to P.I. Branemark and Torsten Gent as they came and gave one of the first U.S. continental training courses for the TIP prosthesis. I sat in a room, and Dr. Branemark showed a picture of what he called an osteoblast on a titanium surface. And he implied that he knew what that cell was doing. And I had just begun my scientific inquiries. And I turned to a colleague and I said, I don't think he really knows, but it would be very interesting to find out. Fast forward, I graduated with my PhD. I'm at the NIH, and I actually began studies of how implant surfaces affect cell behavior. I moved to a job at the University of North Carolina, where I had another great mentor in the dean at present, Dr. John Stam, and my very supportive program director and chairman of the department, David Felton, where I was given the opportunity to build my own program. We did two things. We studied how implants interact with surfaces, and we began our very first clinical trial on single-tooth implants. About 1994, I had the good fortune. I'd been at the school for a year and a half. And Dr. P.I. Branemark came to my laboratory to see what I was doing. And he affirmed in me that the work I was doing was very important. No collaboration was ever struck up with him. But the next thing you know, I'm on the podium at the 1994 AO meeting, speaking right after Dr. Branemark, talking about how titanium influences cell behavior. As I moved along, I found many mentors, one of which was an industry individual. And to your surprise, you may be surprised that my dear friend in industry always reminded me that everything I do had to be at the highest ethical level, and I had to work harder than others and present my material in a more clear fashion than anybody, because that was the way to assure that people would understand the stories that I was telling. I stayed at North Carolina for a very long time and have continued my research. Now I find myself at VCU, a wonderful dental school with a great history of clinical education and a burgeoning research program, enjoying doing what I'm doing, still doing some research on implant surface interactions with cells, still being involved in clinical practice, still teaching, and trying to lead our dental school forward in the next decades. Simple enough.
Thank you, Lyndon. Joe, you have a question?
Oh, I mean, Lyndon, I mean, we've known each other for a long time, and I always look up to your work. Yeah, it is incredible. I looking at your work, and I mean, you are definitely one of the leaders, and look forward to see what you have going here. Okay.
You know, gentlemen, this question about mentorship in career development is so important, because if it weren't for the Larry Tabaks and the John Featherstones, the Jerry Grazers, the John Stams, and others, Jim Shubas, they saw something in me that I didn't see, right? And carrying imposter syndrome around your whole life is a really difficult thing. But there were always these people that challenged you to be the person they saw in you, and it was so important. And we never want anyone to define us, but we do want people to lift us up, and they were remarkable, and I give them great credit.
True mentors.
True mentors.
Yeah. So Lyndon, we want to talk a little bit about digital dentistry. I mean,
sure.
A lot. First of all, in most dental schools now, they are basically pushing the dental students to go digital. And me and you and Bob were educated in the analog world. And dentistry, as you know, is a lot of artistics sometimes more than science. And to be good artists, you got to really work a lot with your hands. And I mean, how do you feel? I mean, teaching the students go digital and they're not really using their hands that much. Will that affect the way they treat patients? What's your opinion on that?
I'm conflicted here, Joe. I know you as a clinician who liked to make his own single tooth implant crowns, match the tooth next to it by doing the own ceramic. And we're born and bred from the same era, and I take great pride in that. I think I've reconciled this by realizing that the goal of attainment is what the important lesson here is. How they get there is less important. But at the end of the day, it's called a DDS, Doctor of Dental Surgery. I know we call others DMDs, but so much of dentistry requires that we put our hands on patients and help them, sometimes heal them, oftentimes address their needs, oftentimes not cure them. I'm really conflicted here. Having said that, I think the future of dentistry really does involve digital technology for three main reasons, and they're not necessarily apparent. The first is that digital dentistry allows us to communicate better with our patients, with our laboratory technicians, and among ourselves. A three-dimensional image is more than 1,000 words. Secondly, digital technology will not make a bad dentist a bad dentist. My friend, the lab technician Lee Kulp, says digital dentistry makes a bad dentist a bad dentist, right? I've seen digital technology elevate clinicians, and I think for people that really struggle but know what the goals are, digital technology can be extremely valuable, extremely valuable. The other is that digital technology can help us with access to care. For example, in our own institution, we've accelerated the rate at which we make dentures by introducing a digital protocol, right? There are fewer try-ins, there are fewer errors, and now we can see twice as many people with the staff and the number of faculty we have. The single crown is a perfect example where same-day crowns changes access to care. And from a business perspective, scanning for a single tooth implant is the most rewarding, both financially and experientially, process to deploy a intraoral scanner that I know of. Scanning for single tooth implants, intraoral scanning for single tooth implants is absolutely the best return on investment those scanners will provide. How do we keep people being able to do this? Great question. I think the answer is put them at a dental chair, get them to see as many patients as possible. Teach them the personal skills and the technical skills at the chair.
Great point. I mean, I want to talk a little bit about edenture situations. I mean, how do you feel that the accuracy of using digital dentistry to apply to full arch digital situations? And I know you have a case to show the audience on that. And can you comment a little bit on that?
Yeah, Bob?
Let's go to slide 7.
Yeah, please. Thank you.
Yeah.
So this goes back to like 2006, 2007. Brian Limmer, who's now our faculty, was the resident. And we're dealing with a gentleman, next slide, please, who really was suffering from all the maladies we know about from the early 2000s in rural communities. Next slide, please. And so we had grown up with Simplant as a treatment planning system. It was called Materialise, and we just understood this was the way we planned things. But at the time, we didn't have a way to make anything from these images. Next slide, please. So we were able to convert our thinking on a screen to our procedures using a guide, but not a digitally manufactured guide, to place implants. Next slide. And also understand how we guided surgically prosthesis. And if you think back a few slides, you saw the prosthesis was in the bony image. And this is something that we learned back in 1993, that if we had an image for a radiological image, we wanted to see the restoration. I worked with Karen McAndrew way back in the day, and we were way ahead of ourselves. We actually had a paper rejected on how to do this way back in the day. And so next slide, please. And we believed in understanding what we're doing. And so not only is planning important for the digital world, but we have other tools in the digital world, such as ISQ measurements of implant stability. At our school, we're trying to create a great database where, in fact, almost every implant we're placing, we're gathering an ISQ value, trying to understand what those values mean in a large patient cohort. Next slide. And then I have always believed in abutment level restorations. And it took a long time to get there, and really immediate loading has helped us understand this. And the quality of an abutment has always been an important aspect of our therapies, but in immediate loading situations, we had to learn how to do this. Now, next slide, please. We did this in an old-fashioned way, and here you see what might have been one of the earliest zirconia restorations. We're going back to 2007, and I'd met Enrico Steger, who had introduced this in Europe. No one had seen this. I saw it in Europe. Mr. Steger and I made a quick friendship, and he offered to do this study of 20 patients that Brian and I published. And so here is a mandibular case, not tilted implants, and Mr. Steger returned this bridge to us. Next slide, please. So the patient goes home, we look at this case, and we began to realize we were making some errors surgically. Go ahead, and they have consequences. Next slide, please. So the consequences is without enough height for your restoration, learning what the realities of zirconia biomechanics was, and learning that you cannot place screw access holes in the thinnest part of the prosthesis, which is an embrasure, we had a mechanical failure. At this point, we began to ask ourselves, what is failure of a case? Because while this edge was sharp, the patient was functioning, the implants were in place, they were healthy. Next slide, please. There's always a solution, right? We had a forced error. Right? Maybe we could have used tilted implants to reduce the cantilever. We certainly could have done a posterior alveolectomy to increase the restorative dimension. Very easy things to fix. But we were able, with the digital file, to not re-impress the patient, but simply ask the laboratory to create a stronger prosthesis. In fact, today what you're seeing here, we call it a bridge base. You can call it a zirconia over titanium bar. This might represent what I consider the most robust and easiest prosthesis to make for an edentulous mandible. 2008. So, Joe, when you think about digital technology and what we're learning is it takes a long time to get smart about this. We'll talk about wisdom in a while, but we introduced this as a clinical study to find out what happened. We did this in a very controlled environment. This was the one fracture out of 20 cases, but when we photograph everything and we watch our cases and we recall our patients, we began to understand how to put rules behind digital technology.
Yeah, a great point, a great case, Lyndon. I have a couple of questions here. First of all, on the same situations like this, and I don't know whether Jim can go back to the first slide there so quickly. And on the same situation here today, if you got a chance to treat this patient again, would you have gone an FP1 instead of an FP3 treatment, FP3 with the bone reduction and that? Would that be even put into your consideration on something like that, rather than, I'm going to use the term aggressive bone reduction, some people may call that?
This is a great photograph to talk about FP1 for FP3. In this case, a 32-year-old individual, I'm going to do the mandible as a conventional FP1 hybrid because it's cleansable. And it's been shown over 40 years that these cases will hold up. I've got lots of original Brannemark cases from the 80s where there's bone loss, but there's no inflammation, that these cases are standing, tried and true. There's no aesthetic deficit to having the FP3 type of an approach with a millimeter of titanium to remind the patient to brush it, the ability to clean it. But when we move to the maxilla, it's a completely different story. This patient has abundant bone. We can see where the sockets are. Placing 6 implants in the molar, canine, and central position, for example, is actually an easy plan. And then to do an FP1 case where we use his tissues to support an FP1 case gives us the opportunity to grow with this patient over a decade or two. And should he have complications, continue on with a robust basal bone, which there's very little of in the maxilla. My concern with FP3 knee-jerk responses to these maxillas, if we remove 6 or 7 millimeters of bone to provide an FP3 at 32 years old, I have a strong feeling that 1, they're not cleansable. 2, we'll have a 40% incidence of periimplantitis. We'll probably have a 25% chance of failure of the prosthesis over 20 years. I'm speculating here. But what do we do for the patient next? You run out of real estate. And so FP1 is a really good opportunity for this specific case. For severely resorbed maxillas, sure FP3. Sure, certainly. But to take liberty for efficiency, take your time. If this is a 3-hour case versus a 1-hour surgical case, it's a lifetime we're giving to these people. There's no rush. We get paid well for the work we do. I think they all have their places, Joe, but I'm glad you asked in this specific case, because when I look at the central photograph here, Joe, this screams FP1 to Lyndon Cooper.
Yes.
Right, and nowadays, I mean, what's your view of there's a lot of speakers out there. I mean, for whatever reason, money or fame, they push for FP1 lectures, right? They all push for FP1. Really, is it really? Is FP1 really that far superior? We
don't know yet. We don't know yet. And this reduction in doing these cases, I'll go back. I think that's what FP3 means, right? The full reduction. Let's be sure I'm understanding the language here.
Yes, that's right? Correct. And people are pushing a lot for FP1 with good papillae and everything. I mean, do they last?
We don't know. And I will tell you that there's a lesson to learn here. You can create papilla if people have an abundance of keratinized mucosa. You can't create papilla in alveolar mucosa. It does not work. Those are lessons we learned 20 years ago doing this work. I will also share, as a prosthodontist, I begin these edentulous cases with an FP3 in the mandible and a complete denture, because I know I can satisfy a lot of patients with a very beautiful maxillary denture. I let them come to tell me what their functional needs are next. I think we're going to see a lot of challenges with periimplantitis in maxillary cases that have flanges that are not cleansable, that have implants placed next to each other that make it difficult to clean them. I can go on and on, but that again is speculation. But from what we're seeing in practices, we're seeing it. We don't see it in the mandible. They're different animals.
Yeah. All right, let's move on. Okay, sorry.
Go ahead, Bob. I mean, what percentage of cases do you think we can do FP1s? I mean, last question on that. What percentage of your patients scenario that we can actually do FP1?
I would say that if you're edentulating a patient for caries without periodontal bone loss, those patients should have a primary consideration of an FP1.
Correct.
I don't know what percentage those patients are. Mm-hmm. If you have periodontal bone loss, I like to move them out of teeth to no teeth for a while, but those patients often have a very irregular alveolar position, and I like to things be symmetrical. So there is going to be an alveolectomy involved. And there's the FP2 in the middle. What's wrong with 13 millimeter long teeth for some people?
Absolutely.
We did that forever in perioprosthesis. No one complained about those either.
That's true. Right. All right, let's move on to our next topic here.
Sure.
Let's talk a little bit about wisdom. So how do you define clinical wisdom, Lyndon, and what advice would you give younger clinicians who are eager to develop wisdom early in their careers rather than relying solely on experience over time? And let's talk about what role do mentors play in transferring this wisdom safely?
I hope I remember all three of these parts, but Bob and I talked about this months ago when we talked about doing this, and there's an entire literature on wisdom in medical science.
Yep.
And there is a progression from collecting data to assembling it to information, from taking that information and creating knowledge, and then from knowledge, developing wisdom. Data is periodontal probing measurements on a record. Information is making a diagnosis of periodontal disease and putting a classification to it. Knowledge is understanding the root cause of the disease and being able to apply the appropriate therapeutic approach in an academic environment. Wisdom is knowing what to do with the knowledge, right? So we've just talked about FP1 versus FP3. There's plenty of data out there that says they both work, but for whom? We have a case with the single tooth, don't we? Could we show that?
Yes, go to slide 19, please. Yep.
This is a very simple example of wisdom. So we know how to restore single tooth implants. There's nothing important about this, but a 62-year-old non-white Hispanic female with type 2 diabetes with what she considered a controlled HbA1c level, but we were suspicious. A lot of things cried out here. And I extracted her tooth and sent her home. And you may ask, well, that looks like a great immediate loading case. Next slide, please. But type 2 diabetic, and we have to start making some decisions about the knowledge we have. Okay, she's a type 2 diabetic. She has, I didn't mark this out, she probably has a 50% bleeding on probing index. She's got evidence of oral inflammation. And I've got to start asking myself, like, do I want to use stage therapy? What do I do about altering my antibiotic prophylaxis? Do I need a longer integration period? And do I want to consider delayed loading? And in fact, all four of those things come with a little wisdom. Did the patient want an immediate loading procedure? And unfortunately, they hear about this and they come to us today asking for it. So now we have to teach our patients. Next slide, please. So the opportunity was to extract and let this site heal a good 16 weeks and then place an implant using a surgical guide, using guided surgery to plan, using digital technology to plan the case, and then letting the implant integrate in a one-stage surgery for a period of 12 to 16 weeks. Next slide, please. Yeah, the basis for some of this, or some of the basis for this thinking, is actually founded in great data. Tom Oates did this great study looking at healing of type 2 diabetics versus those who are controlled, and he showed that the ISQ values really changed dramatically in uncontrolled diabetics. As a bone biologist, we know this from the work we do studying healing of bone in experimental diabetic animals. So I'm a firm believer that we take all of the data, the knowledge that we have, right? The data is their H1C, H1B, HbA1c levels. The knowledge and the information is what is synthesized on this slide. But the wisdom is, who do we apply this to and why and when? Next slide, please. So I want to streamline these procedures. I believe that every interaction with biology opens up the opportunity for failure. Biology always wins, my friends. So what you see here is one of the best uses of digital technology. I'm going to simply place a scan body, make a scan. Next slide, please. Use the opportunity to create a core file, which allows me to make a crown and an abutment. So the next time I see the patient, I can just deliver this crown. And Joe, the funny thing, we were talking about hands-on skills. I get the core file, I take it to a mill, I scan it, I stain it, I glaze it, because I enjoy it. It's my style of practice. I want every dental student to experience that joy. I don't know if I can get there, right? But success for now. The key for this patient is to understand what is the supportive implant therapy guidelines we will place this patient on. If you don't deploy, if you just use knowledge, then it will tell you that you should have a supportive implant therapy program. If you use your wisdom, it will tell you that maybe for diabetic patients, you need to be more suspicious. And my general comment to everyone is never turn your back on a healthy implant. They will stab you. So what we want to do here is put this patient on a little bit more robust implant therapy, implant supportive therapy regimen. Maybe not once a year, maybe not twice a year, maybe 3 times a year, maybe preserving her other teeth and making sure that her bleeding index comes down and that we monitor this for peri-implant mucositis so it never advances to peri-implantitis.
So let's touch back again, the role of mentors in transferring wisdom safely to these students and to young clinicians.
I think just because you see it doesn't mean you can do it. Just because you see it doesn't mean you should do it. And so this is the issue with learning on Instagram. We have students that come into the school every day and say, hey, did you see what I saw on Instagram? Yeah. I've seen it on podiums too, where I call it podium prosthodontics. Someone invents the best 17 steps to doing something remarkably complex and interesting that you'd never want to deploy in your practice, right? Just because you see it, should you do it? I mean, I think our mothers always told us, if Jimmy jumped off the bridge, are you going to jump off the bridge too? That's a perfect example. So just because you see it doesn't mean you should do it. Yeah. And I think this is where true mentorship comes. What relationship do you build with someone that is built on trust and admiration, and where you actually know the difference between someone that's telling you honestly what the world is about, what dentistry is about, and someone that is selling you a story or a tale that may not be real? Yeah. I think the way you measure this is you find out where your mentors sit in the world of professional dentistry or academics. So you ask yourself a couple questions. Is my mentor a member of X organization? Has my mentor published anything in a peer-reviewed journal? Has my mentor served on his local dental society and contributed to the well-being of our community? Those are people you seek as mentors, right? It's very important to understand. We've all had them. We've all had them.
Yeah, Lyndon, I mean, as you know, we all know that in dentistry, most procedure, whatever we do, within the first year, they usually work pretty good. Longevity. I mean, how long do you expect your work to last? What is a good number?
Yeah, well, Joe, when I was a young prosthodontist, there were people who told me prosthodontists do great work and their work never fails. That was a goal. You built a case for life. When Dr. Brannemark brought in the 1960s his osseointegrated implant to the world, he was treating edentulous people who were 65 who had a life expectancy of 77. Longevity wasn't a problem.
No.
Right? Think about where we are today. When I give lectures, I ask this question all the time. How many of you have ever seen a 40-year-old dental implant? No one, except the oldest person in the room may raise their hand. And then they'll say, but it was a sub, and that doesn't count. Like, okay. And then I ask the audience, how many of you placed or restored an implant in an individual less than 40 years old? Half the room raises their hand. I said, do you think you know what you're doing? And the answer is we don't. And what is the solution? Unlimited optimism and a remarkable commitment to excellence. Because all we can do to assure longevity is the very best work we can do. No shortcuts for anybody. That's the only way we can treat people today, because we don't have answers for longevity. I also no longer believe that our work lasts forever. And Joe, you've been on the podium now for several years showing cases of 17 and 18 years. We know what happens, right? We know things change. And it's like I said, never turn your back on a healthy implant. So my view of longevity is that success is measured by the quality of the journey, the quality of the therapeutic journey, not the initial 1-year outcome, not a 5-year outcome. The case I showed earlier with the failure, that's not a failure. He's still walking around with that bridge. He had a complication, but in a clinical trial, the bridge failed. Did his therapy fail? No, the doctor was there to care for him. Did informed consent inform him that perhaps this was a complication? And people will lose implants, sometimes catastrophically, right?
Love your point. I will always remember it's a journey.
No.
It's a journey that Bob, as you know, once we put that implant in, it's going to be a journey. And but maybe in retrospect, looking at a lot of cases, sometimes maybe it's better to try to save that tooth. Yeah. So we never let that journey begin.
That's just the first part of the therapeutic journey. If I can get 10 years out of a tooth and I'm a wonderful clinician, I know that patient will be back when they have a problem. And I know what the right solution then is, right?
And I think, Lyndon, you have a perfect case to share about.
Yeah, let's see.
Go to slide 26, please.
Yeah. So my idea about longevity is this simple equation that risk times time equals trouble. And so what we want to do in longevity, as I said, is do excellent work and do great planning and make great decisions using wisdom to mitigate risk. Next slide, please. This was a young lady who came to me with external root resorption. Next slide, please. And so you can see remarkable root resorption. The problem was she was a dental student at the time. And by the way, this was a long time ago. And interestingly, we were just beginning an immediate load, our very first immediate load clinical trial. And so I enrolled her in the trial against the best wishes of many faculty, and I placed the implant according to what is now our 3-2 rule, which, Joe, we didn't even know then. We just were doing it that way because a great periodontist, John Moriarty, another of my mentors, he and I had an argument about where implants should be, and we decided 3 and 2. And so you can see the provisional, next slide, and the final restoration. And what we learned in the study early on is 85% of the time we could control the vertical position of the soft tissue such that it never moved from where we were at the time of surgery to where we were 5 years later. But that's a study. Go to the next slide. This is a live patient. She comes back to my office in 2014. This is about 12 or 13 years after the case. The 2004, I believe, is the 3-year follow-up. And she, as a dentist, notices that she's got relative tooth intrusion. And she asked me what I could do. Well, for me, this is simple. This is part of the journey. The difficulty now is I've got to remove a crown. By the way, this crown might have been the very first Empress milled crown in the United States. Next slide. And so we now had new abutments. And I said, not only can we do this over, we can do this better. So we grabbed the titanium abutment, which rather zirconia abutment, which is studied in a previous study. Next slide. And I changed the abutment. Sorry for the little bit of soft tissue. I think my hemostat grabbed her gingiva as well as the crown. My apologies there. Placed this new restoration for her. Next slide, please. And she was able to continue along her way for a second decade of success. But there's a biological basis for longevity. The peri-implant tissues were healthy. Her understanding of her responsibilities for maintaining it were clear. And my ability to replace this restoration with a better abutment and now an Emax crown of probably nearly equal aesthetic value, one that was certainly satisfactory to the patient, gave her a second decade of success. My questions, Joe, is where will we be in the third decade? We don't know.
Yeah, great point. I actually have an interesting question I want to ask you. And
Sure.
Also, I want Bob to also chime in on this too. So right now, knowing what you know, what will be the youngest age, patient's age, that you're willing to place an implant if the patients are needing a maxillary anterior implant? What will be the youngest age?
Wisdom. If a patient at 18, if a woman at 18 understands the risks of intrusion and she truly understands that we cannot estimate if it will or how much it will be intruded, and a single tooth implant seems to be the very best treatment for that patient. And remember, our experience with single wing zirconia resin bonded bridges is becoming remarkably challenging to the single tooth implant scenario. That aside, if a patient really insists on having an implant restoration and they understand the relative risk, and we do a great job, and it's an ideal case, tremendous amount of keratinized tissue, good bone volume, we can place the implant without great risk, without anything but supplemental grafting, which I think every implant needs. Joe, you showed us that years ago. Yeah. I'm okay placing that implant. But if the patient has any concerns, I don't have an answer for them. So let's try something else. But the data is very clear. Age is not a factor in intrusion.
So 18. The answer is 18. And Bob, can I add a little twist? I want to ask Bob this question. Same question, but however, let's say the patient is your dear daughter, that need an anterior implant. What would be the youngest age you're willing to put that implant, knowing what you know?
I wouldn't change it personally. Treating friends and family, especially family members, that is a big concern. That's a big red light in my mind. So, but Lyndon, if you could answer that, that would be great as well. But what about boys? Because I've seen
older.
I mean, I saw a college, he was in the GPR program, and he grew, so he's probably in his middle 20s. He grew 4 inches in dental school.
I grew 3 inches in college, 2 inches in college. This is an issue. Men are different.
Yep.
And it's the single tooth in a young adult. When young ladies and young men come with syndromic cases and they need multiple implants replaced, it's a different story. Place the implants. They're healthy. Yeah. But yeah, Joe, we have a case at the university right now that we're conflicted about. And is there an alternative? Is there a good alternative that will get them 5 years down the road? And there may be. Sometimes there is not. Yeah. So every case is different. Every case is different.
Okay, let's go to our next question, Lyndon. Let's talk about planning versus execution. How can intraoperative decisions, especially under stress, everyday stressful, negatively affect long-term success and longevity? And do you think we consistently prioritize longevity in these moments, especially in light of Frank Renard's Swiss cheese model for understanding implant complications? And please go, Jim, to slide 38.
Yeah. So This is an interesting scenario because you have to ask yourself, what am I looking at? And it brings up 2 points. Maybe at the end of this, we'll get to wisdom, but this patient showed up in my dental chair saying that she hated her prosthesis. She didn't understand what was going on. And I was the 5th or 6th clinician she'd seen. Next slide, please. This is the condition that this patient's in. The prosthesis has been in place for years. Okay, the implants have demonstrated no bone loss, but she has a prosthesis that she finds absolutely unacceptable and unappealing. She says she can't smile, she can't eat, she can't chew. Next slide, please. So I've removed the prosthesis, and I thought I was going to spend 2 days cutting it off. And I finally just said to myself, well, what if I tap it off? And it came right off. And you can see the gold nuggets that are abutments. And you can see the implants placed in remarkable positions. And you have to ask yourself, well, how did this occur? And there are a couple answers. One is, well, it was early in the evolution of implants. No one knew better. 2, no one knew what they were doing. 3, there was no surgical guide. 4, this was a novice. I can go on and on. But all other people have declared this case as non-restorable. And go back, please, one slide, Jim. Everybody suggested removal of all of those implants. Now, that's a very brave.
Morbidity is amazing if you do that.
I don't know what you're going to have when you're done. Next slide, please, and go forward one more, please. So I decided to do what I know how to do. I will make a denture, putting her teeth in the right place, and determine what I can do. And what I found out was I could build a prosthesis. I had to, quote unquote, sleep an implant in the number 11 position, but I was going to be able to make her prosthesis. Realize one of her chief complaints was the bulge underneath her nose on the right side. Next slide, please.
Yep.
I removed the prosthesis. I cleaned things up. You can see the canine implant. I've just cut it off at the level of the soft tissue. And remarkably, things got healthy quickly because I gave her a prosthesis she could now clean. And I asked her if she would be accepting of this type of prosthesis. Well, it's a little bulky up there, Dr. Cooper. I said, well, those peak abutments, these are an older style Zimmer implant. Fortunately, they make these nice peak abutments. I said, we'll make something a little thinner for you. Next slide, please. And so I turned to my dear friend Enrico Steger back in the day when people were just getting started. By the way, this was before they had CAD-CAM technology. This is what they called their madman parallelogram. So they would do a wax up, and then they would mill everything in a parallelogram copy mill situation. And this is the prosthesis I received. Remarkable, right? Remarkable that he was able to make something. Next slide, please. And it came in multiple pieces. So we had screw access challenges that he tried to hide by cementing crowns over it or one under it. And she was so pleased with the outcome. Next slide, please. I believe we have one more. That we were able to build this prosthesis, make it cleansable, give her a prosthesis. And the result was, as I was leaving the university, she was so distraught that she asked me a simple question. Can you make me a spare? And so what I did was I called the lab and I said, remember the file you had? Can you duplicate that for me? What's the cost? So they gave me the cost and they said, I'll return the duplicate for you in 2 weeks. So they returned the duplicate file to me in 2 weeks. And what I was able to do is just return to the patient this beautiful box with a duplicate prosthesis that she keeps in her nightstand, because if Dr. Cooper's not there, another dentist will be able to replace her broken prosthesis. Because it's the journey, right? I want her to have a successful journey, and I will not be there to care for her. But this shows you that mistakes are made clinically. And my decision was to leave her whole. And taking those implants out would have been a disaster. And this is not an ideal case, but it's a successful journey, and she was happy. But back to your original question, should you make decisions about failed treatment plans sitting at a dental chair doing surgery? And my answer to my residents and to myself is it's the worst possible place to make a decision. Take off your gloves, step away, go sit down, take your mask off, look at your records, think about what has gone wrong, and then look at what the goal of therapy is. Because the goal of therapy is not to save your tail, get out of surgery fast. The goal is to make the best decision for the patient. Yeah. Sometimes that may be, oh, the immediate case failed today, Ms. Smith. We're grafting. Thank goodness Dr. Cooper's made a denture for you. It's only going to be 12 weeks till we see you again. We're fine. And, you know, it takes a great deal of self-confidence to tell somebody that things just aren't working the way we planned, but we are going to make the very best decisions for you in the heat of the moment. We've all blown a buccal plate bone, right?
No.
We've all had spinners. And I've seen countless times when implants have been placed in the worst positions because there was good bone there and we could make a case work. Not ideal, but we could, quote unquote, make it work.
Yeah, Lyndon, I have one final question for you. I mean, it seems to be a trend nowadays that a lot of clinicians love to extract good teeth, you know, to do an All-on-X type of, you know, either FP1 procedures. And how would you respond if there's a young graduate student or a local dentist show you a case that, oh, you know, I mean, you see obviously very good teeth, and he or she, this clinician, want to take out all the teeth and do an All-on-X, and you say why, and the response is, oh, patient wanted it. What's your view on that? How do you feel on situations like this nowadays?
How much confidence do we have to educate our patients? They see on television, your teeth don't work, your dentistry has failed, let's just take all your teeth out because there's something better. There is actually no evidence that implants are better than teeth. In fact, the longevity data that comes from Tord Berglund suggests just the opposite. So scientifically, we don't stand on very good grounds to remove teeth, healthy teeth, or teeth that can be restored. I've seen remarkable cases where I wish someone would have, you know, you're down to 6 remaining mandibular teeth and there's caries on them, and you've got a maxillary arch that has 7 or 8 abutment teeth. And I often wonder why they go to a dual arch therapy where in the same amount of time, I can prep and provisionalize the maxillary teeth for a beautiful milled temporary prosthesis supported by teeth, and turn around in the next hour and a half and do the immediate load mandible and give them exactly what they need without doing 2 arches of therapy. I think people actually believe treating implants is so much easier than treating teeth, number one. Number two, they think there's a lot more money in it, which probably is not true. And number three, they don't think about what the long-term outcome could be, right? I have a big problem. I'll tell you a quick story. I went to Poland to give a hands-on course, and it's difficult to do this. So we did a treatment planning course, and I had 4 different cases of full arch restorations. And I wanted to see if people were going to understand the value of sinus grafting. They were going to understand how to distribute implants. And I was shocked because what came back, I divided 24 people into 6 groups of 4 and had them to present the 4 cases, what they decided. 24 people in 6 groups decided that every case was going to be All-on-X.
Yep.
That tells us where we've gone in terms of the marketing of dentistry. I don't know if it's right or wrong. I don't feel good about extracting healthy teeth. And again, you know, here we are in a multidisciplinary organization where we can reach out as surgeons, periodontists, prosthodontists, and restorative dentists, and bring our endodontist in and ask the simple question: do teeth last?
Yeah.
And how can we do that? I don't think we're giving ourselves enough credit for the skill that we hold in our hands today.
And had the decision made by a team. I mean, the case you showed with the planning and the execution was off because of the times and whatever. But, you know, I always got my prosthodontist or my restorative colleague involved. I never want to be the last decision on taking out all these implants if my prosthodontist or my restorative dentist felt that they could restore the case as you did. I mean, you made one really happy patient there.
Yep.
Everything that she had to do was traumatic. I mean, we took multiple surgeries, probably sinus slips,
years,
horizontal bone grafts, vertical, everything, years. So, or she ended up in a denture, a full denture. Yeah.
Or she would ended up with a communication, which, you think about it, it could become traumatic.
Yeah. And it's all about planning and execution, as you mentioned. I love that term.
It's the journey.
Complications are that. So, all right. So I'd like to just say a few things here at the end here. So I'll be
quiet.
That may be hard, right? Okay. All right. So Lyndon, thank you for sharing your story and wisdom. It's been a real privilege. We're grateful for the impact you continue to make on our profession. We really look forward to seeing really how your vision at VCU keeps shaping the future of dentistry.
Thank you.
So to wrap up, we'd like to share a few books, audiobooks that continue to inspire curiosity, keep us growing on the path of lifelong learning. And Jim, please go to slide 48. So as we've done in the past, you could see we're bookworms. I mean, this is lifelong learning to me. This is what I start at the beginning of every day and the end of every day. So just love it. And Hotseat 5, Hotseat 6, Hotseat 8, some terrific books here from the speaker as well as our co-hosts as well. Lyndon, you want to talk a little bit about your recommendations in Hotseat 9?
I looked at what the other hot seats were, and I saw there was this trend to looking at leadership books. And I just asked myself, what's the most influential leadership book you have read? And it goes way back to one of the originals, The Leadership Challenge. And so I would recommend anyone that has any interest in leadership, just go back and read The Leadership Challenge, learn the 5 principles in that book. It's just a great read. And, it's stood the test of time. There's lots of books out there, and everyone will develop their own leadership style. And what I tell my team today is all I can say about leadership is learning.
Yeah.
Right? Every day. I make mistakes. I recover. I analyze what I've done as a leader, and I try to do better the next time. But the Leadership Challenge gives you a framework on how to do that work. And it is work. On a lighter note, there's this author named Edward Rutherford. Yeah. And I chose his book, London. And I guess you put Sarum up there because we discussed it, because they go together. Yeah. This is an historical novel that follows the path of a genetic family, if you will, from prehistoric times of Stonehenge to industrial London. And along the way, you get to meet some fascinating people like young William Shakespeare and others. But it's such an enjoyable read, and it asks of us to understand the times in which we live. And I can't think of in the last 3 decades any more important time to ask ourselves, what is it specifically about the times in which we live? These are very big books. They're great reads. They're about 1,000 pages each.
Yeah.
And I was a history major in college, so things like the book Longitude, which is the story of how the competition from the Royal Society of building a clock that worked on a ship, great book, but they're different. And then another in this venue would be Galileo's Daughter, the wonderful story about the letters written to Galileo. There are people in history that just have remarkable stories to tell. This is different. This is a family that goes from prehistoric times to post-industrial London. They're great books. They will keep you entertained for many days.
Yeah. And I threw the Elif Shafak's book in because it's a recent read, just beautifully written about 2 rivers, actually, the Thames and also the Tigris River. We'll be visiting Turkey. So I thought that was a really interesting read, a lot about history in Mesopotamia and, where the world actually began. And the other books I put in is leadership and a lot about founding fathers and John Meacham with Lincoln. I mean, we're celebrating in America our 250th anniversary of the 1776 Declaration of Independence. So if you've watched the Revolutionary War series, Atkinson was really portrayed very well. So a couple of his books. So just some other good reads. I like to listen to these books in the car also. Makes it more interesting. But I think, Lyndon, I want to ask you one last question about today. If you could leave clinicians with one mindset shift or words of wisdom that would most improve long-term outcomes, can you share that with us, please?
I think it has to be learn with colleagues, right? Learn with your colleagues. Develop lasting professional relationships. And recognize the smartest guy in the room is going to be someone you never expected, right? Yeah. It's so refreshing to be sitting in a room and see someone who you recognize is going to change the way you practice or make you think strongly about what you do. And those are great days. Those are great days. This profession has been so rewarding to folks like us. But I think for me, I can't speak for you, the reward is being able to meet people like yourselves, converse with folks like you, and continue to teach and hope that dentistry is better for the next person, right?
Yes.
It's been very rewarding and very, very satisfying.
And that's what I think we do very well, is the mentoring aspect. Joe, you want to leave us some final words from your end, from Zurich, Switzerland?
Well, really, Lyndon, it's an honor. It is an honor to co-host with you, first of all, Bob. And Lyndon, I've known you for a long time. And like I say, you are basically a model dentist for a lot of young, both prosthodontists and surgeons. Your wisdom is incredible, and I've learned a lot from what you share. And I'm sure may all of us continue to be students in the art of dentistry forever.
Right. So if we all take care of ourselves, practice wellness, take care of those around us, and take care of our profession, it'll be a great day the next day.
Yes.
Yeah.
Yeah, I want to share one thing, because we had PD Miller on our Legend series, and PD for the last 15, 20 years has been sitting on my right shoulder saying, Bob, you could save that tooth. And guess what? Just like you, Lyndon and Joe, I travel a lot, and I see different programs around the country and the world, and I see so many teeth being taken out that, oh my gosh, these teeth should have been saved, not an all-on X. We could break this into different crown and bridge sections or whatever. We could save teeth. And the research is really coming out. AI is now showing us we could save teeth as well. It's better than frequently the option. So,
and here we are at the Academy of Osseointegration, actually promoting saving a few teeth.
Well, that's not a bad thing.
We must all remember it takes great skill and knowledge to save a tooth, and hard work to save a tooth. Pulling a tooth is just simple. Drilling a hole, everybody can do that, and put a piece of metal in.
I think that's what we're seeing. Yeah. They find it simple.
And some of the reasons it's easier. It's not long-term. Longevity shows that it's not. The teeth will outlast frequently the implants. So just to keep that in mind. So on our last slide, Jim, we'll promote our next hot seat, 40 years, real cases, hard-earned wisdom, from Mike Picos in Florida. So I want to say stay tuned.
It'll be April
great. 1st, Ismail Cooley will be my co-host, live at 8 p.m. Eastern time. So again, Lyndon, Joe, really appreciate you coming out in the middle of the night in Zurich to join us. And Lyndon, I hope you're feeling better, but we got through this together. Thank you so much, Lyndon, for joining us and sharing your wisdom.
It's an honor. It's a pleasure, gentlemen. I hope you have a great evening. Folks, thank you for listening.
We'll speak soon.
Bye, guys.
We have to stay on, by the way.